I'd like to welcome Dr. Alan Hammond to the studio now. He is the Executive Chairman of eHealth, and he's a winner of the World Healthcare Congress 2012 Health Innovation Award. Dr. Hammond, congratulations on that.
Thank you.
Please describe to me the program that got so much attention.
Well, we're trying to build a health infrastructure in places where there isn't any that works, right? You have government clinics, but they're not staffed, they're not attended, they don't have diagnostics. And for rural parts of the developing world, that's it, right? Or you have informal practitioners, quacks, witch doctors. How are people supposed to get health care? And particularly if it costs a day's salary or more to travel to the nearest city. And if you're a woman, that means you have to take a family member too. So we're building small clinics and water treatment centers, water points we call them, and health points. And we're building them in the Punjab part of rural India to start with. And they do four things. They give you access to doctors over a video screen, because there are no doctors that want to live in rural parts of the world, even in the US, but certainly in rural India. And then we have a full diagnostic lab, so he can send you down, or she, the doctor, can send you down the hall and check and say, yes, that is malaria. And then they can hit their mouse key and print out a prescription, and you walk down the hall to our pharmacy and you buy the right medicine. And so that's the treatment part, but the preventing part is water, because waterborne disease is huge. And in a third of rural India, there is no source of safe drinking water for the community, no. So we take the local water and we treat it, and we provide it. So that's interesting, because we're doing preventive, but the fascinating thing is that we're trying to make money doing this at prices that poor people can afford. So we charge 80 cents for a doctor consultation, $1 on average for a diagnostic test, and $1.50 for a family's monthly supply of drinking water. And we are breaking even.
How do you do that? Is the equipment expensive?
We use technology. I mean, broadband has come down. The water treatment things are no longer patented. They're less expensive. The diagnostic, point-of-care diagnostic tools are undergoing a revolution. Fairly soon we'll have labs on a chip that can do a DNA analysis in 5 minutes in a rural area. And so we're using technology aggressive, and then we basically use doctors very sparingly, and they're back in the city. So our local staff are all trained from the village.
Yes.
And at local salaries. And we shave costs everywhere we can, but that's basically what we're doing. And many people have said, in effect, that if we can show this works at scale, maybe in several countries, we really will change the paradigm.
Yes.
Right?
Right.
Because we're essentially saying free but ineffective care could be replaced by high quality care that low income people can afford. And that's a scalable model.
Does that apply only on the things that you've been talking about? The equipment to treat the water and these diagnostic tests that are fairly inexpensive already because they're generic.
Rural broadband is coming down and becoming available everywhere.
Can this be expanded to other services?
Yes, we think so.
Like what?
Well, so we have the only urban...
Surgeries?
No, not surgeries. Yeah, I think those are more tricky.
Okay.
But let's talk about a lot of things that rural villages need. We have the only urban quality facility in that village. You know, think of McDonald's, right? They all look alike. They have glass, they're modern, they're clean. And we have broadband, we have backup power. So in addition to those, we could do chronic care management. Diabetes, hypertension. We're about to move into antenatal care and inoculations and nutritional supplements, right?
Okay.
You come every day to pick up your water, you pick up your nutritional supplement.
Yes.
We could sell solar lanterns for people who have unreliable power. We could be the cash-in, cash-out point for a remittance system, right?
Right.
And so, in a sense, the idea is to become a one-stop shop for many things that village needs, but what gets us the access is providing health care.
How are these villages reacting to these kinds of services? You say pretty good. Did it take a little while to educate them on the benefits of trusting outsiders to come in?
Yeah, well, they're not really very much outsiders because the staff they see are from the village.
Okay.
But I think that we need to refine our business models for healthcare better. Walk-in clinics everywhere in the world are sort of marginal as a business. They often have to be subsidized. So we're moving more into what we call package services. So here's a fixed fee for your pregnancy. Covers all your consultations, all your tests, all your supplements. You know in advance what it's going to be. You pay a little bit every month. And you come at times that we schedule you. Now I can use my doctors more efficiently because I know when the traffic's going to be there. Right? I don't have to be fully staffed at every minute. Same for diabetes management. And chronic care management and maternal and child care are of much greater public health value than sore backs and sore throats, which are the staple of walk-in clinics.
Yes,
right?
yes.
So we're going to move upstream a little bit into these higher value services. And we also think they make more sense from running a sustainable business. But we're going to expand the water by adding nutrition to it. We're going to expand some of these other services. And so we're still tinkering with the model, but in the meantime we're growing very rapidly. The water we're starting to put out on its own as the beachhead, and we're doing 20 units a month, 20 villages a month.
Do you have any hard evidence of how many lives this has saved?
Not yet, but we have commissioned a third-party group, one of the premier poverty analysis units, to do that kind of, it's a 3-year outcome study. And they're already doing the baseline now, because we know that if you really want to change the opinion of the global health community, persuade health ministers, you need that kind of data. So we're in the process of gathering it through a third party that is credible.
And finally, for other companies that are being approached to do something similar, who have the equipment, the technology, the expertise, how do they look beyond this being something charitable?
Well, so we're doing it as a social enterprise. We're a startup, and we set out from the beginning to do this both in terms of transforming the quality of care, but also by showing it could be profitable, because that's the only way to attract enough capital and enough other players in the field to make a huge difference. And interestingly enough, we are being looked at pretty carefully by some very large hospital chains in Asia, by very large consumer goods companies that are attracted particularly to the water piece. And, and so we think once we get a little further along and can show closer to commercial return on investment, then there will be suddenly a lot of people who want to snuggle up, right?
Yes, absolutely.
Or steal it and copy it and compete with us or whatever. But
Right.
in some sense, when there are 4 billion people who are unserved, head-to-head competition is sort of meaningless,
Yes,
right?
absolutely.
There's infinite market.
There's definitely a lot of audience
And the
members
key
there.
is to show the big companies in the capital markets that you can actually make money, not huge margins, but you can make reasonable margins providing high quality care to poor people.
Yeah.
And that's the revolution we're trying to foment.
Okay.
And that's basically what the award was for, that it says, hey, this is a system change, potentially.
Yeah.
Let's sprinkle a little pixie dust over them.
Very good. Dr. Hammond, congratulations again.
Thank you very much.
Thank you. I'm Mabel Jung. Thank you so much for watching.